So we're moving on after yesterday's discussion and we take on further questions now. So the first question we'll cover there is a 22-year-old woman comes to the ER with palpitations, right? She develops syncope and becomes hypotensive, and ECG is ordered and the trace is shown. What's the diagnosis? Now, before we look at the ECG, look at the sequence of events is that she's come with palpitations and in the ER, she develops syncope and becomes hypotensive. So, what does that tell you? That tells you something was wrong that was causing palpitations, and then it decayed into something else, it became something else, or a complication occurred, which is why she developed hypotension and syncope. Right now, you look at the ECG and you see that your inference is correct. Is that initially what was a wide complex tachycardia decayed, and there were some wide complex waves, and then it decayed and it became a VF, right, where no appreciable PQRS or T waves can be appreciated, right? Then you look at what your options are. Atrial fibrillation, obviously not. Narrow complexes with irregular RR intervals and no P waves, right? So this is not AF, certainly. This is what AF would look like. Yes, narrow QRS complexes, irregular RR intervals, and no visible P waves, right? Then the second choice there was ventricular fibrillation. So VF alone, yes, there is a segment, there is a part of the trace here that is showing ventricular fibrillation, yes, but that's not the complete story. What they have told you is that she came with palpitations and she developed syncope and became hypotensive. So something that was going on decayed into something else, right? So a VF is chaotic complexes, irregular in amplitude. See, the amplitude is very, very variable. There are no recognizable P waves, QRS complexes, or T waves, right? Wide complexes without any recognizable waves of varying amplitude. That's what a VF will look like. Another option was monomorphic ventricular tachycardia, and a monomorphic ventricular tachycardia will obviously be the QRS will have a single morphology, right? And you won't see unrecognizable trace complexes on the ECG. So you see that it's a wide complex tachycardia. And what you see here, the complexes, the QRS complexes in one lead are of the same morphology. Now, what's this? Right, these waves here. What are these waves? These are capture beats. See, what happens in ventricular tachycardia is usually there is complete AV dissociation, right? And sometimes when the ventricle is not refractory, one of the supraventricular impulses passes to the ventricle, and these beats are called fusion beats or capture beats, right? This is what establishes that the patient is having AV dissociation. So wide complex tachycardia in which the QRS complexes have same morphology in a single ECG lead, that's monomorphic VT. What you're dealing with here is a polymorphic VT, right? So multiple different types of QRS complexes is what you're dealing with here, right? And you see capture beats in between, right? So what this is Torsids depointus, if that's how you pronounce it, right? I think this was fairly straightforward. All right, moving on. We've discussed these ECGs in brief. High output cardiac states. I think it's a tricky question. Which of the following is not a high output cardiac state? You've been reading this from your first year, right? Beriberi, anemia, thyrotoxicosis, fever, exercise, right? So definitely beriberi is a high output cardiac state. Systemic AV fistula is a high output cardiac state, as is anemia. Now, cor pulmonale, if they had said chronic lung disease, that would have been a high output cardiac state. Cor pulmonale it's a surrogate term for right heart failure. if you look at end diastolic pressures, then the distinction is that cor pulmonale is a dilated right heart that's not yet failed, right? So right ventricular end diastolic pressure is still normal in cor pulmonale, right? But this, remember, is largely a pressure driven hypertrophy, isn't it? Why does it happen? It happens secondary to chronic lung disease, and the lung is the only organ in the body. The pulmonary circulation is the only vascular bed which responds to hypoxia with vasoconstriction, right? And when that is chronic, it becomes pulmonary hypertension. And to overcome that increase in pressure in the pulmonary circuit, the right ventricle hypertrophies, and that enlargement of the right ventricle is called cor pulmonale. And gradually, as the end diastolic volume increases, it dilates, its size increases. It is able to compensate for the increase in pressure and volume by virtue of fiber stretch, but there comes a stage when it cannot compensate anymore. The fiber stretch, the Frank-Starling law, I love that law, is fiber length, muscle fiber length is directly proportional to efficiency of muscle contraction, right? Now, there's an upstroke as fiber length increases, efficiency of contraction increases, but there comes a point where there's a precipitous fall in efficiency of contraction, right? So, cor pulmonale should be the answer to this question. Not a straightforward question, isn't it? Okay, let's keep moving. So, very quickly, Blackfoot disease. I don't know whether you knew this or not. It's seen in Taiwan in a group of people, and it's because of the water supply being contaminated with arsenic, right? They'd ask you, Wind-Kessel effect is not seen in which vessel? The choices were the aorta, the renal artery, the carotid artery. I'm not sure whether they said internal, external, or common, but carotid I remember. And they said the radial artery. Now, the Wind-Kessel effect is seen in elastic vessels, which is the aorta and its branches, and the pulmonary arteries, right? It's an impedance effect, which allows blood flow to occur even during diastole. So it's not seen in the radial artery, right? Okay, moving on. Left hemi-neglect, they asked you a question on that. A man is brought by his son. The son says that his father doesn't use his left arm and leg. So, doesn't use the left arm and leg. He also doesn't wash the left side of his body. A drawing by the man is shown. Lesion in what part of the brain is responsible for these manifestations? So, this is the drawing that was given to the patient, and this is what the patient was able to draw when we gave this drawing to the patient, right? So you can obviously see that he's left out. So there is left hemi-neglect. I mean, we can obviously identify that without having to explain it. Now, which part of the brain is responsible for it, right? Obviously, it's going to be the right brain, right? So now, is it the right motor cortex or the right posterior parietal cortex? So it was fairly simple. If you know functions of brain lobes, it was very simple, but I'll approach it in a little more systematic manner for you. So that's the differential diagnosis of contralateral hemiparesis, right? And you can see that cortical lesion, posterior internal capsule lesion, midbrain lesion, pontine lesion, medullary lesion can all cause contralateral hemiparesis, right? We are not interested in any the last four of those, so we'll block them out, and we'll look at what happens when contralateral hemiparesis occurs because of cortical lesion. So we're looking at additional features. When it's in the dominant hemisphere, which is the left for most people, there will be an associated language deficit. Again, I hope you know that already. If it occurs in the non-dominant hemisphere, like our patient here, it's going to cause contralateral neglect and apraxia, right? Now, again, we still don't know whether this is the right motor cortex or the right posterior parietal cortex, which you come to know from here, is that the parietal lobe is responsible for visuospatial orientation, and therefore its dysfunction causes hemi-neglect. The frontal lobe, these are the functions of various segments of the parts of the frontal lobe. So of course, it's one, the motor cortex is in the frontal lobe. The association areas, the supplementary motor areas are responsible for motor planning. So apraxia will occur with a motor cortex lesion, but hemi-neglect would not, right? So the answer to that is the right posterior parietal cortex. Okay, right, moving on. Then they ask you a question on which is not a reversible cause of dementia. Again, I think this was fairly simple. You can correct hypothyroidism with thyroxine hormone replacement. You can correct normal pressure hydrocephalus, which is the DIG, the dementia incontinence gait syndrome, with ventricular peritoneal shunting. You can correct B12 deficiency with B12. Megaloblastic madness is the dementia that occurs with the Lewy body disease. Once you have degeneration, it cannot be corrected, at least so far. Maybe one of you will correct it, yeah, with a monoclonal antibody. Yeah, sweet dreams. So these are the reversible causes of dementia. Alcoholism, depression, when it's because depression is called pseudo dementia. NPH, we just discussed that. Visual impairment can look like dementia, and it's potentially modifiable. And drug and medications. Why is it important to know the reversible causes? It should be obvious. When you see a patient with suspected dementia, what you rule out first of all is reversible causes, because you can reverse them, right? That's a exhaustive list of less common causes of reversible dementia. You can pause this here if you want to and knock yourself out. Irreversible causes, all the degenerative ones, Alzheimer's, vascular dementia, Parkinson disease dementia, again, Lewy body disease spectrum, and late, right? And then these are the less common causes of irreversible causes of dementia, right? Um, take your pick. Okay, and they're given an image where they're asked what is the sign being elicited. Again, simple, I won't spend time here. It's the Babinski sign. Acute hepatitis B. They gave a patient who developed acute hepatitis B, and this was followed by a full recovery. Which antibody of the IgG type is marked by X here? This, right? So these are the serology markers. What appears first is HBsAg. I'm just talking of serology, right? Of course, the E antigen will appear first before the S antigen will appear, and the AST and ALT will start to rise even before that. And even before that, the patient will start to develop it. The illness will start with malaise and fatigue, and maybe a day or two of fever, and then anorexia, and jaundice will appear. As jaundice appears, just before that, a couple of days before that, the transaminases will rise, right? And that's the HBsAg. In full recovery, the patients become HBsAg negative in about 6 months' time, right? Now, the green trace here is IgM anti-HBC, which is how you make the diagnosis of acute hepatitis B, right? The orange trace is IgG anti-HBC. Anti-HBS only appears after 6 months, right? So that was how you were supposed to answer these questions. Someone might think that the confusion here could be between anti-HBS and IgG anti-HBC. So IgG anti-HBC appears first, and anti-HBS only appears after about 6 months. And this dashed period in between is called the window period, when the only serological marker is IgG anti-HBC. Okay, right, moving on. So they'd given a patient who who's a BMT recipient, a bone marrow transplant recipient, and the patient developed a lung infection for which He underwent a pulmonary dissection. They had shown the specimens. So there was a gross specimen with clearly demarcated. There was a single lesion. This is something I picked up off the net. So this is what I could come up with best. And this is what gives you the diagnosis: angled septate, acutely angled branches from septate hyphae, obviously. And this then confirms there is clearly demarcated lesions. The patient is having invasive pulmonary aspergillosis. Again, I don't think there was a problem there. Then they gave you a patient who had undergone a heart transplant and now has come with fever and pulmonary infiltrates. You do a KOH smear of sputum, which reveals oval budding yeast cells and pseudohyphae. So you found Candida on a KOH smear of the patient's sputum. Now they had asked you what this implies. So if you look at lung infections that occur in solid organ transplant recipients, you will see that they have pneumocystis infections. You will see that they have CMV pneumonias. You can see that they have histoplasmosis, sometimes blastomycosis, but never Candida. Candida does not cause a pneumonitis. Okay, so the answer here, and what does this, and where did this come from? It is a colonizer of the oropharynx, which it quite commonly is, even in the immunocompetent individual. A colonizer, mind you, I'm not saying it's causing disease or infection, right? So the answer here was that you cannot draw a conclusion from KOH smear of sputum, which is why a KOH smear of sputum in someone with a pulmonary disease, in someone with a lung disease, acute lung disease, is of no consequence, right? Now, if you had drawn this sample after a bronchoalveolar lavage, that would have been significant, right? And especially if you had seen it on a biopsy. If you had done a bronchoscopy and taken a lavage, or you had done a biopsy, then this would have become significant. But again, remember that Candida does not cause airway or pulmonary infections. There is no such entity called a Candida pneumonia. All right? Okay, moving on. So the point here that I was trying to make is that a KOH smear of sputum is pretty much a meaningless investigation when you're trying to diagnose a pulmonary illness. Okay. Then they gave you a patient who underwent splenectomy 5 years back. He's bitten by a dog, and there's a tiny puncture wound on his thigh with surrounding erythema. The man and the dog have received all their vaccines. What should be done next? So what you're worried about is capnocytophaga canimorsus. It can cause fulminating sepsis in splenectomized individuals, and the best drug for these patients is co-amoxiclav. Amoxicillin clavulanic acid is what this patient should receive prophylactically. If this were not a patient who was splenectomized, then you needn't have done anything, right? I'll move on. A critical care physician inquires about an organism. It's a gram-negative bacterium that's resistant to Carbapenems, aminoglycosides, and Quinolones. And it is susceptible to cotrimoxazole and ticarcillinic clavulanic acid. What's the likely organism? And I remember three choices from there. Pseudomonas aeruginosa, absolutely not. Possibly either of Burkholderia and Stenotrophomonas maltophilia. Let's look at those organisms. Burkholderia cepacia causes a lot of troublesome infections in cystic fibrosis patients. It responds to cotrimoxazole, meropenem, and minocycline. Now, this was resistant to carbapenems. Definitely, Burkholderia is not your answer. Stenotrophomonas is responsive to cotrimoxazole and ticarcillinic clavulanic acid, in addition to levofloxacin and tigecycline. So that was your answer there. All right, I'll move on. They'd asked you what the mechanism of action for plasma exchange or plasmapheresis in thrombotic thrombocytopenic purpura is. So if you knew that it's because of anti-ADMTS 13 antibodies, then the answer was also simple, right? So it not just removes the anti-ADMTS 13 antibodies, it also replenishes the enzyme, right? There was a question on iron deficiency anemia, and I don't think I will need to discuss that. Very simple: low serum iron, low ferritin, high DIBC, and a low transferrin saturation, right? Nothing to write home about there. Or multiple correct, all the choices were correct, right? We'll move on to a more difficult question. They said that in a diabetic patient, a drug is administered which leads to improved, I've written fasting twice, sorry, fasting and PP sugar levels, increased active levels of GIP, uh, increased GLP-1 induced insulin secretion, and decreased glucagon levels. Which of the following drugs has these attributes? Difficult question to answer, I would have thought. Liraglutide, which is what most of you marked, allogliptin, uh, DPP-4 inhibitor, alpha glucosidase inhibitor, and a myelin analog, pramlintide. Let's look at each of those drugs more closely. So, GLP-1 RA, liraglutide, promotes oral carbohydrate induced insulin secretion. And this doesn't happen in response to IV glucose. This is called the incretin effect. I would like you to make a note of what the incretin effect is. Right? Incretins are substances that promote oral carbohydrate induced insulin secretion, and this effect is not seen with intravenous administration of glucose. This effect is called the incretin effect, and there are two incretins naturally occurring incretins. One is GLP, the other is GIP, glucagon-like peptide and gastric inhibitory peptide. So coming back to liraglutide, it lowers fasting and postprandial sugar, and it lowers glucagon production. Now we go to the DPP-4 inhibitor, allogliptin, because it blocks the breakdown of both GLP-1, the DPP-4 enzyme, which is ubiquitous in the body. All the cells have it. Break down GLP and GIP, and because these agents inhibit that enzyme, they lead to increased active levels of both GLP and GIP, right? But here comes the catch. In the euglycemic and hypoglycemic state, they enhance glucagon production. It also improves both fasting and postprandial sugar, right? Uh, I'm sure that most of you didn't know that, but I'm also sure that most of you did go with liraglutide, and that was a lucky choice. So never mind. Sometimes luck also plays its part. Nevertheless, please look at these attributes carefully. What they will do next time is they twist the question. They twist one factor here or there, and then you'll be stuck, right? So alpha glucosidase inhibitors will not allow absorption and therefore reduce only postprandial sugar. I'm talking of glucose. And then pramlintide, which slows gastric emptying, therefore only lowers postprandial sugar, but it does suppress glucagon production, right? How an anti-diabetic medication, what it does to glucagon production is an important factor. So please try and remember that for all the classes of drugs, right? Okay, I'll move on. This was simple. Anti-diabetic, they give a female who you gave an anti-diabetic medication, the glycated hemoglobin and HbA1c improved, but the patient developed a vulvovaginal infection, and what causes that is the SGLT2 inhibitors. The drug given in your paper was canagliflozin, right? So that was fairly simple. There was a question on rheumatology, a solitary question. A housemaid has skin thickening and develops numbness of fingers on cold exposure. So you're dealing with systemic sclerosis, right? And this numbness of fingers and cold exposure is Raynaud's phenomenon, right? Now, she also has difficulty walking and climbing stairs, so there's a myopathy. The investigations revealed already done are she's ANA positive, CPK is elevated, the muscle biopsy shows perifascicular atrophy, right? So the elevated muscle enzyme and the muscle biopsy picture confirms that there is a myositis overlap, right? The anti-youth, which antibody test will confirm the diagnosis is what was asked. So the myositis overlap with scleroderma is associated typically with the PMSCL antibody. Right, let's quickly look at systemic sclerosis specific antibodies. Diffuse cutaneous sclerosis, systemic sclerosis, is associated with the SCL70 or topoisomerase 1 antibody. I think that this was also one of the uh, positive findings that was given in the stem of the question. Right? That's what I remember. Anticentromere is the antibody that's associated with CREST syndrome. RNA polymerase 3, importantly, it signifies a lot of things. What I would like you to remember is that it signifies that there's high possibility of rapid progression of disease. Anti-U3RNP, which is one of the choices, or anti-fibrillation, is associated with pulmonary artery hypertension. The worst prognosis of all varieties of pulmonary artery hypertension, of all those, and U3RNP or antifibrillary is what is a marker for that. U1RNP is a marker for mixed connective tissue disease, which is polymyositis, right? Rheumatoid arthritis, SLE, and systemic sclerosis. Okay, then this is the antibody that they had asked you. How do you know that this is a scleroderma myositis overlap? Jo1 antibody is seen in idiopathic inflammatory myopathies and in ILDs in patients. Those patients with polymyositis and dermatomyositis who go on to develop interstitial lung disease will also have anti-Jo1 antibodies. Then there was a question on kidney biopsy. They're asked about kidney biopsy, which of the following statements are incorrect? And there were multiple choices that were correct. So incorrect, correct. I hope that's not an oxymoron for you. So they had said FSGS cannot be diagnosed on percutaneous biopsy. It cannot be diagnosed on a superficial biopsy, right? So if you take a superficial biopsy, you get normal glomeruli, and you might think your patient has minimal change disease. So you need medullary glomeruli. So you need to take a deep biopsy, right? So this is definitely wrong. FSGS can be diagnosed on percutaneous biopsy, but I also told you that should not be a superficial biopsy, right? Patients must be observed for 24 hours after a kidney biopsy. In most centers around the world, they are observed for 24 hours. In a few centers, they can be discharged after 4 hours, where you image the perirenal space immediately afterward. You monitor blood pressure pulse rate closely for the first 4 hours. If there is no perirenal hematoma, or if there is a perirenal hematoma less than 40 ml, you can discharge the patient after 4 hours. But I would say that this is a statement that's correct. Most centers around the world keep their patients for 24 hours after a kidney biopsy. If a patient is passing large clots in urine after a kidney biopsy, it raises suspicion of a hematoma. So, gross macrohematuria after kidney biopsies is fairly common, right? It does not raise the suspicion of a hematoma. It usually resolves spontaneously. Even large clots can be present, and sometimes, if the patient is catheterized, they block the Foley's catheter, and you have to then irrigate the catheter. So definitely this doesn't raise the suspicion. What is the suspicion of a hematoma? If immediately after biopsy or any time after the biopsy, the patient has severe flank pain, especially if it's associated with a hemodynamic instability. That means the patient develops tachycardia and or hypotension, right? Even tachycardia alone with severe flank pain, you should image your patient, right? But usually, when do you have the suspicion of hematoma? See, I just said that gross hematuria after a kidney biopsy is self-resolving, self-limiting. But when that gross hematuria, mild flank pain, and fall in hematocrit, when these three continue for more than a week, is when you worry about a hematoma and you should do an imaging. Okay, so this is not a true statement. Okay, now the last choice was, in a patient suspected of having systemic amyloidosis, the kidney should be biopsied. Even if you didn't know this is incorrect, one careful look at the choices would have told you, because D was included in all the four options. So why should you not biopsy a patient with systemic amyloidosis? Is because of two reasons. One, doing a kidney biopsy in a patient with renal amyloidosis can precipitate renal failure. That's one problem. The second is not a problem, is an opportunity, is because it's systemic amyloidosis. You can take a biopsy from the lip, from fat pad, take an aspirate from the fat pad, or you can do a rectal biopsy. All right, that's it from my side. Till next time, I'm signing off.